I am a pediatrician and I will be teaching you today regarding the ambulatory management of beta thalassemia major. So we know that beta thalassemia is a hemolytic disease. It is a hemolytic disease which causes intrinsic hemolysis in people. It is an autosomally recessive inheritance pattern of disease, and this disease is caused by defective in chromosome 11. So we know that chromosome 11 is the gene which is affected in beta thalassemia major. So what happens in this disease? So this is a genetic disorder where the beta globin chain production is reduced or the beta globin chain production is completely absent. So this will lead to increase in the alpha globin chain, and these alpha globin chains will precipitate inside the RBCs, and these RBCs which has excessive amount of alpha globin chain will be destroyed. So because it is an autosomally recessive inheritance genetic disorder, there is 25% of the offsprings of the parents who are both carriers of beta thalassemia trait to get the disease. That means that if the father is a carrier, if the mother is also a carrier, then the child has 25%. Each children has actually 25% chance of getting the disease, and 50% chance that their offspring is a carrier, and there is 25% chance that in every pregnancy the child can be born normal. So this beta thalassemia is also known as Cooley's disease, and it is caused by a genetic disorder affecting the chromosome 11. So as I explained, there will be a beta globin chain that is reduced, and this unpaired chain will cause precipitation and immature destruction of the precursor RBCs, causing shortening of the RBC lifespan. So if you see beta thalassemias based on the severity of the clinical features, we can classify beta thalassemia into silent, moderate and severe. In other terms, it's called as beta thalassemia trait, beta thalassemia intermedia and beta thalassemia major. So beta thalassemia major is a situation where both the beta globin chains are absent. So there is no beta globin chain production. In beta thalassemia intermedia, what happens is either both hemoglobin chains are beta globin chains are reduced, or one is reduced and one is completely absent. This will cause significant anemia in the patient. However, the child will not be transfusion dependent. In beta thal trait or thal minor, this is a silent form where if you see one beta globin is always normal, whereas the other beta globin can be either absent or reduced. So in this peripheral smear, what do we see? So the RBCs in the peripheral smear will be microcytic. RBCs in the peripheral smear will be nucleated RBC, hypochromic, and target cells will be present. So you can see microcytic hypochromic anemia with target cell and nucleated RBC. This nucleated RBC shows that there is premature precursors RBCs are produced. So coming to the pathophysiology of beta thalassemia major, so what happens is if there is an absence of beta globin or if there is a reduction in the beta globin chains, there will be an excess of alpha globin chains. This will cause precipitation of the erythroid precursors within the bone marrow. Also, there is membrane damage to the peripheral RBC. This will lead to ineffective erythropoiesis and hemolysis. Because of the precipitation of the erythroid precursor, there will be ineffective erythropoiesis. Also, because of the damage to the membrane damage to the peripheral RBC, there will be hemolysis. This will cause anemia in the child. So the anemia is caused because of ineffective erythropoiesis and also because of hemolysis. So anemia, what will this in turn cause? This anemia will cause erythropoietin increase, because now this is a place where the hemoglobin content is low and the bone marrow is actually functional. Bone marrow is actually functional. So bone marrow will try to increase the erythropoietin levels. Erythropoietin levels will increase, and what happens is there will be expansion of the bone marrow. expansion of bone marrow. So erythropoietin levels will be increased and there will be expansion of bone marrow, and also because there is an anemia, the body will in turn try to take the iron back to the body, so there will be absorption of iron. So, and also when the anemia is beyond the lower limit, we always transfuse these children, and because of the transfusion the children will be having iron overload features, which can cause deposition of iron in the cardiac muscles, which can lead to cardiac death in these patients. So coming to the clinical features of beta thalassemia, as you can see in this picture, this child is having hemolytic facies. There is prominent maxilla, there is crowding of teeth, there is prominent frontal bossing, and this is called hemolytic facies. Hemolytic facies. Earlier it used to be called as chipmunk facies. Chipmunk faces, and this current terminology doesn't use chipmunk faces, it is called hemolytic faces. In this x-ray you can see the extramedullary hematopoiesis from the skull, which leads to a crew cut appearance, or this is called crew cut appearance or hair on end appearance. Hair on end appearance. Also, the child or the patient will have other clinical features like there will be dark urine, there will be hemoglobin urea, there will be abdominal swelling because of hepatosplenomegaly, there will be excessive fatigue because of anemia, there will be weakness because of anemia, there will be facial bone deformities because of extramedullary hematopoiesis, and there is jaundice because of hemolysis, jaundice secondary to hemolysis. So the hallmark of treatment is regular RBC transfusion plus iron chelation. So the treatment that we offer for thalassemia patients is before the hematopoietic stem cell transplant is regular RBC transfusion and iron chelation. So we know that about like children with transfusion dependent thalassemia major are born worldwide, and among these 10% is from India, which is a huge burden, huge load on India. So in the absence of a treatment, most patients with beta thalassemia major is going to die before the age of 5 years. So this is a disease where the life expectancy can be increased because of the regular blood transfusion and further definitive management in the children. So beta thalassemia, as we know, it can be again classified into thalassemia dependent, thalassemia non-dependent. So thalassemia dependent will be your beta thal major, and thalassemia non-transfusion dependent will be a beta thal trait or intermedia. So transfusion dependent, when do you call it transfusion dependent? When the patient is transfused more than 8 times in a year, or non-transfusion dependent if they are transfused intermittently or they have never been transfused. So why do we transfuse? What is the goal of transfusion? What should be your cutoff? And what are you preventing by transfusing these patients? So you know the goal of transfusion here is to prevent chronic hypoxia. So because of the hemoglobin being less, there is reduction in the oxygen carrying capacity of the blood. So this will in turn lead to hypoxia, and this hypoxia will lead to growth failure in children. This in turn can present as stunting. So because of this chronic hypoxia, I am going to prevent. But this chronic hypoxia can be prevented by transfusion to prevent serious growth, neurological and skeletal complication, and also to suppress the erythropoiesis. So I am going to reduce the compensatory marrow hyperplasia and also the compensatory GA absorption of the iron, because already the child is being given multiple transfusion. On top of that, if the child is continuing to absorb iron from the intestine, the child is going to go into iron overload status faster. So I'm going to prevent iron absorption in these children. To prevent hypervolemia secondary to marrow hyperplasia and also early splenomegaly and hypersplenism. So once the spleen grows beyond the size, like if it becomes a massive splenomegaly, then the child will have hypersplenism features. So we are going to transfuse on a regular interval to prevent the hypersplenism. So what are the types of transfusion that is available in beta thalassemia management? So we have something called hypertransfusion, supertransfusion and moderate transfusion. We call it hypertransfusion when the HB levels to be maintained is 10, it is supertransfusion is 12, and if it is 9 to 10 it is moderate transfusion. In most of the Indian settings we use moderate transfusion where the HB is maintained between 9 to 10.5. If it is more than 10 it is hyper, if it is more than 12 it is super. So you can remember the value 9, 10, 12. Moderate, hyper, super. What are the indications for transfusion? So when you have a confirmed diagnosis of thalassemia, you see lab criteria and clinical criteria. If the HB is less than 7 on 2 occasions, 2 weeks or 1 week apart, or if there is a clinical criteria, irrespective of the hemoglobin level, if the patients have severe symptoms of anemia, if the patient has CCF features, poor growth failure, if the patient has failure to thrive, excessive intramedullary hematopoiesis features, like if the child has already developed a pathological fracture, then you have to consider early transfusion. You cannot wait for the hemoglobin to fall less than 7. So blood transfusion, least amount of plasma to prevent hypersensitivity. You have to transfuse the least amount of plasma. The plasma content in the RBC then the blood should be very minimum, and it has to be the grouping and typing has to be done, and both the major and the minor blood group incompatibility should be checked. And besides that, you have to use a bedside leukocyte filter to prevent alloimmunization, HLA alloimmunization, CMV infection, and improved storage of erythrocytes. Leukocyte reduction less than 10^6 is a critical threshold for eliminating these adverse reactions. So how frequent should you transfuse the child? So volume and rate of transfusion will depend on the patient's age, the clinical status, the preservatives that are added, the hematocrit of the donor RBC, and your target level of hemoglobin. So it's based on the patient's age, the target HB, the hematocrit level of the donor RBC, the clinical status, and also the preservatives that are being added in the blood product. Average rate of fall in HB will be 1 gram per week. So if it is HB 10 this week, after 4 weeks it is going to become 6. So you have to call them mostly between 3 to 4 weeks. You have to call and transfuse, and you have to maintain a mean HB of 12. Maintain mean HB of 12. Rate of transfusion for CDPI units with a hemo concentration of 75%, you transfuse 10 to 15 ml per kg. If it's cardiac failure, you transfuse 5 ml per kg in children. Weekly transfusion you can give. Now how will you evaluate? So now you are giving regular transfusion for this child with beta thalassemia. How are you going to evaluate this child? So annual pure red cell consumption is the most useful indicator. Splenectomized patients with a mean HB of 12, then you can have a indicator of 130 ml of pure red cell per kg per year. Non-splenectomized should have a higher requirement. So their requirement is 130 ml of pure red cell per kg per year. What are the causes of high blood consumption? When do you have to transfuse even more frequently? If there is hypersplenism, if there is red cell incompatibility, or if there is poor quality of transfused blood in the patient, then you will have to transfuse this patient even more faster. What are the complications of the blood transfusion? The main complications, as you know, because of any transfusion is infection, So you have to test the donor blood. So you know that hepatitis B is only vaccine preventable blood-borne transmitted disease. So hepatitis B vaccine should be given to all new thalassemia patients, and you have to check the antibody titers. What all adverse reactions can you expect? Any adverse reaction that is pertaining to the blood transfusion is also found in the same cases of thalassemia. Non-hemolytic febrile transfusion reaction, allergic reaction to the plasma protein, acute hemolytic reaction, autoimmune hemolytic reaction, TRALI, graft versus host disease, all these can come in patients with beta thalassemia when they are given blood transfusion. Now coming to iron chelation. So iron chelation is a major adjunctive therapy that is given along with blood transfusion for patients who are awaiting for hematopoietic stem cell transplant. So you have three forms: deferasirox, deferrioxamine, and deferriprone. Deferasirox, deferrioxamine, and deferriprone. So when do you transfusion and iron overload? So 1 unit of Paxil is going to give 200 mg of iron. 1 unit of Paxil, 200 mg of iron. The iron per ml of blood is 1.16 into hematocrit of the transfused product. So transfusion of 100 to 200 ml per kg of PRBC each year. So if you give monthly 10 ml per kg, then it is 100 ml per kg if you give it for 10 months. Each year delivers an estimated 116 to 232 mg per kg per year of iron to an individual. And now there comes a concept of non-transparent bound iron. What is non-transparent bound iron? So iron overload causes saturation of transferrin. Now because there is excess iron, non-transparent bound iron will be there. So you have something called transferrin which will bind to iron. This is a carrier. Whereas when the iron is more, there will be free iron. So this free iron is called labile iron. This labile iron will cause tissue damage. So the uptake depends on the organ's capacity to respond to the labile iron, which is reflected by calcium channels within the tissue. So myocardial tissue, hepatocytes, endocrine organs, all these will accumulate the non-transparent bound iron, which is common compared to the other issues. So the major organs affected are heart, the liver, and the endocrine organ. So what happens? So if you see here, so you have free reactive iron. This is going to cause reactive oxygenation species, and this is causing oxidative stress to the endoplasmic reticulum, to the mitochondria. This is going to cause protein misfolding, oxidative damage. So this will also lead to all this damage because of the reactive oxidation species, and also this chelation is in turn going to cause it is going to send the free iron through urine, and it is going to excrete out of the body. So now coming to the damage. So where all the damage occurs? Damage can occur in the pituitary because it is an endocrine, and this is going to cause hypogonadotrophic hypogonadism. So if boys will have delayed puberty, girls and boys will have delayed puberty, it is going to affect the thyroid. So it is going to result in thyroid deficiency. It is going to affect the heart, which is going to cause arrhythmia, cardiac failure. It is going to affect the liver. This is going to cause liver fibrosis and liver cirrhosis. This is going to affect the pancreas and also the secondary hypogonadism. So measurement of iron overload. How do you measure the iron? You can measure serum ferritin. So when do you measure the serum ferritin? If there is more than 10 transfusions or level is between 1000, you have to start chelation and you have to monitor the trend of the ferritin. And next is liver iron concentration. So you know that apart from heart and endocrine gland, liver is a place where iron is being stored. So liver iron concentration is the most reliable indicator. It's the most reliable indicator. And average value is 1.8 mg per dry weight of the liver. And how do you quantify it? One is through biopsy and one is through an MRI kind of technique. And then another is something called SQUID. What is SQUID? Superconducting quantum interface device. So this will cause a electromagnetic wave that will find the level of iron inside the liver. It's a non-invasive procedure, because biopsy is invasive. Either you can go for SQUID or for MRI as a non-invasive procedure. Cardiac iron concentration can also be monitored through T2-weighted MRI. Now, how do you manage this iron overload? So you have three types of therapy: preventive therapy, rescue therapy, and emergency therapy. What is preventive therapy? So the iron chelation should be done before the organ damage. So before the end organ damage, you are going to do an iron chelation. This is called prevention. Rescue therapy, significant iron overload in tissues with changes in the end organ. So once the end organ damage has happened, you are going to prevent the complications because of that. And emergency therapy is when the complications of the end organ damage, that is like CCF all, has happened, and you are going to try to rescue the patient. So there are three types of therapy. One is preventive therapy, rescue therapy, and emergency therapy. So patient will present with cardiac failure secondary to unchecked cardiac overload. So when to begin the iron chelation? So when will you begin? So if the serum ferritin is more than 1000, after 10 to 20 blood transfusion, the child should be above 2 years of age, and hepatic iron concentration should exceed 3.2 milligram per gram of dry weight. So what should be an ideal chelator? Now we had studied about the chelators. Now we will see about what is an ideal chelator. So ideal chelator should be an oral preparation, should not have any chelator related toxicity. It should be non-expensive, because you really don't know when you will get a hematopoietic stem cell transplant in settings like India. So it should be non-expensive because it's a long-term therapy. They should bind to the labile iron, because this non-transferrin bound iron is a potent reactive oxygen species. So it should be binding to the labile iron, which is in a constant state of production. And a steady level of chelator is essential to optimize the efficacy in binding to the available labile iron. So what are the three things we have? So earlier we saw desferrioxamine, deferrosirox, and deferiprone. So defferrioxamine. So is it fulfilling the ideal chelator requirements? We'll see that. So properties: it takes up iron from various iron contained proteins. So its T half is 20 minutes. The iron deferrioxamine compound ferroxamine is excreted in the urine and the stools, red color to the urine, and it is an IV. We wanted something that is oral, whereas this is IV. So absorption is enhanced by supplementing vitamin C. It can be recommended doses is given here, and the dose of desferrioxamine is also given. So what are the side effects of using desferrioxamine? So we have seen here, this is a subcutaneous or IV injection. You're putting the subcutaneous port in the periumbilical site, and there can be local reaction in the form of pain, itching, and erythema, and also there will be auditory and visual complications. So the main complication of desferrioxamine is auditory and visual. Auditory and visual complication. Visual complication in the patient, auditory and vision is affected, and this is also going to cause growth retardation. There will be stunting, there will be skeletal changes in the patient, there will be skeletal changes, and also there will be increased susceptibility to Yersinia infection. So these are the complications you have to remember: ear, eye, growth, bones, and the bacteria. Ear, eye, growth, bones, and the bacteria. So regular estimation of iron overload and Porter's index. So main dose by the serum ferritin level. So you can know the quantity of desferrioxamine required. Next is the deferiprone. Deferiprone therapy is the first oral iron chelator for children more than 6 years. So we told that if the child is more than 2 years itself, there are chances that the child will become iron overload, whereas this deferiprone can be used only for more than 6 years. So it chelates iron from parenchymal tissues and the reticuloendothelial stores, and your T half is 135 minutes. 135 minutes is the T half, and it's excreted in urine, and it is available as capsules. What are the side effects? So you can have GI side effects. So there can be GI side effects in the patient. There can be leukopenia. So RBC, WBC count will be reduced. Leukopenia, and counts at done at 2 to 4 weeks interval should be discontinued. So we have to monitor counts. There you are monitoring for eye, hearing, and the bone and the growth and Yersinia infection, whereas here you have to do CBC regularly. If the count is below 3000, leukopenia, if the ANC is less than 1000, or if the platelet is less than 1 lakh, you have to discontinue the therapy. There can also be arthropathy and musculoskeletal pain. Pain and arthropathy can be there, and can also lead to zinc deficiency. Zinc deficiency can be seen in deaf very prone. Deaf very prone is more prone for abdominal GI, arthropathy, leukopenia, zinc deficiency. So you remember bones and GI. So bones, what do you see there? There will be bone marrow suppression. Bone marrow suppression causing leukopenia. Bone marrow suppression that leads to agranulocytosis, and there can be arthropathy and musculoskeletal pain. Then comes the deferoxerox. Deferoxerox is also a oral iron chelator, can be used in 2 years of age, and the dose is 20 to 40 mg per kg per day before a meal. So it can be dispersed in water or apple juice using a non-metallic stirrer. What are the side effects? You can have nausea, vomiting, diarrhea, skin and renal and hepatic toxicity. So here it is hepatic toxicity, creatinine and SGPT you have to monitor. So we saw deferoxerox, deferriprone, ferrioxamine. So in ferrioxamine you are thinking of Yersinia. It is IV and local pain and causes. This is bone marrow suppression, so you have to monitor the CBC levels. This is going to cause hepatotoxicity and renal causes. So this one you have to monitor the SGPT and creatinine. Creatinine SGPT you have to regularly monitor. Loss of zinc and calcium in unit, you have to give zinc and calcium also. So now there is something called shuttle hypothesis and combination therapy. What is this combination therapy? Chelation. So it's a proven efficacy. The simultaneous combination works on shuttle hypothesis, whereby one chelator will mobilize the iron and other one will chelate the iron in the plasma. So we know that this iron is being accumulated in the endocrine glands, in the heart, in the liver, and there are also blood is having some non-transferring bound iron, and then you have to throw it in the urine and the stools. So what happens here is one medication will mobilize all the iron to the blood. One will bind to all the mobilized iron and put it back in the urine. So this is called the shuttle hypothesis. Shuttle hypothesis. So desferrioxamine and deferriprone combination has been validated to reduce the life-threatening iron deposition. Deferoxerox and deferriprone also have been shown to reduce the liver and cardiac iron toxic with tolerable toxicity. So when do you consider intensive therapy? Now we saw that if a child is more than 2 years, if the child is requiring more than 10 to 20 transfusion, or if the ferritin is more than 1000, we are supposed to start iron chelation. Now when will you consider intensive therapy for this child? So if the child is having severe iron overload, like the very high ferritin level, if the iron is more than 15 mg per gram per dry weight, or if there is significant cardiac disease like dysarrhythmias, LV failure, heart iron overload in the T2 weighted MRI, or prior to pregnancy or bone marrow transplant, we have to do intensive therapy. So coming to the key points, as we saw, the desferrioxamine is going to have visual field effect and high frequency hearing loss. Deferriprone is going to cause agranulocytosis and arthralgias, and you are going to monitor the CBC for this patient. Deferoxerox, you have to monitor SGPT, creat, as it is going to be toxic. So this is what all we have to monitor in a child with beta thalassemia. You have to monitor the pre-transfusion HB, a CBC, growth, ferritin, OTPT, creatinine, urine for microalbuminemia if the child is on deferoxerox, calcium, phosphorus, alphos and vitamin D3 on 6 monthly. This is because of the intrinsic medullary hematopoiesis, and also the auditory and ophthalmic evaluation. Now coming to an adjuvant therapy that is called hydroxyurea. This is a DNA anti-metabolite that is going to increase the HbF production. This is a DNA anti-metabolite that is going to increase the HbF production, and this reduces the risk of leg ulcer, pulmonary hypertension and extramedullary hematopoiesis. This is mostly used in sickle cell anemia and can also be tried in beta thal major. So the dose will be 10 to 20 mg per kg and the side effect is going to be cytopenia. And this is an ambulatory care of beta thalassemia. So the definitive management, as we know, it is hematopoietic stem cell transplant, and India is on the way to try to treat most of the beta thalassemia patients with hematopoietic stem cell transplant, and in near future hope most of the patients will get evaluated and also will be eligible for stem cell transplant.